Good afternoon, everybody. This is Nurse Eunice with Florida Training Academy. And in today's video, we're going to be reviewing critical care nursing. We have a practice test for you. So we're going to give you about 10 seconds to receive your notifications. And yes, we are starting early because I have another task, another engagement. So we're going to get started in about 5 more seconds. And good afternoon, everyone. So, welcome to your or our critical care nursing review. Whether you're a nursing student preparing for your first critical care rotation or a returning nurse brushing up on essential skills, this review is designed to boost your knowledge and confidence. We'll cover key topics in managing critically ill patients with rationales to ensure you understand not just the what, but the why behind each decision. So, let's dive in and strengthen your ability to deliver the highest level of care. And don't forget to like the video and to subscribe to our channel for more resources and study guides. Hello again, everybody. All right, so I saw some of you already putting the answer in the chat, so you know this one. What is the primary goal of critical care nursing? Is it A, to administer medications, B, to provide basic care, C, to monitor and stabilize patients with life-threatening conditions, or D, to assist with feeding? And hello, my darlings. I missed you all so much. I know it's midweek, it's Tuesday, but I hope you have been having a fantastic week. All right, and so we're going to reveal this answer in 5 seconds. 4, 3, 2, and if you chose C, you're absolutely correct. So, critical care nursing focuses on monitoring and stabilizing patients with life threatening conditions, often involving advanced technologies and interventions. Which of the following is a hallmark sign of septic shock? Okay, so your patient has an infection, a very severe infection. Is it going to be A, hypertension, B, bradycardia, C, hyperglycemia, or D, hypotension that is unresponsive to fluids? And now I'll give you 10 seconds to answer this one. All right, we'll reveal the correct response in 5 seconds. 4, 3, 2, and D is the correct response. So, with septic shock, the person has severe hypotension that normally would respond with fluid resuscitation, IV fluids. However, in this case, it's not. So, we have to give additional medications in addition to IV fluids. And those medications are called vasopressors. So, septic shock, low blood pressure, fluids, and medications to raise the blood pressure, in addition to antibiotics. In a patient experiencing acute respiratory distress system, also referred to as ARDS or ARDS, what is the most appropriate oxygen delivery method? Respiratory distress. All right, so is it A, nasal cannula, B, simple face mask, C, non-rebreather mask, or D, mechanical ventilation? All right, I see a lot of D's, so let us see. And you're absolutely correct. So if you chose D, you are aware that ARDS patients typically require mechanical ventilation due to severe hypoxemia and impaired lung function. All right, let's go to our next one. What is the best positioning for a patient with increased intracranial pressure or ICP? So let's think of a patient who maybe had a traumatic brain injury and they're post-op. They've had their surgery. So what position do you want them in? Is it A, flat on their back, B, in the Trendelenburg position, C, in a semi-Fowler's position, or D, in a high Fowler's position? Someone with a brain injury who has increased swelling in their brain. How do you want them positioned? I see a lot of correct responses. So we'll reveal the answer in 3, 2, and it is C, everybody. So the semi-Fowler's positions helps to reduce the ICP, or the intracranial pressure, by facilitating venous drainage from the brain. So we sit them upright, not in a high Fowler's position, but more like in a reclining position, and that's going to help the fluid, the excess swelling in the brain, drain down into the circulation. All right, so which of the following rhythms requires immediate defibrillation? Is it A, atrial fibrillation, B, ventricular fibrillation, C, sinus bradycardia, or D, ventricular tachycardia with a pulse? So whenever you think about defibrillate, that means this person is pulseless. They are no longer with us. They're in cardiac arrest. So which of these rhythms would be a pulseless rhythm? And I see one correct response so far, revealing the answer in 5 seconds. 4, 3, 2, and looks like Fatima and Amy, you have it. So the way I want you to remember it is that we defib for VFib. So we defibrillate for ventricular fibrillation. VF is a life-threatening arrhythmia that requires immediate defibrillation to restore a perfusing rhythm. So while we're waiting for that machine to charge, don't forget, we're on that chest doing high-quality CPR. Which intervention is the most appropriate when managing a patient with neurogenic shock? Now, let's divide those words up. Neuro, what part of the body are we referring to? Okay, so neurogenic shock. Are we going to do A, administer fluids, B, administer vasopressors, C, place the patient in a Trendelenburg position, or D, apply heat packs? Neurogenic shock. Well, we kind of knew from the last shock that we were administering fluids. So let's see. We know it's not D. So that means it's A, B, or C. And I'm revealing the answer in 3, 2, and I see a lot of C's. Let's see if that's the correct response. It is B. Neurogenic shock often results in hypotension due to vasodilation, and vasopressors, those medications that help bring the blood pressure up, are needed to increase the vascular tone and the blood pressure. I know you're going to get this one. In patients with burns covering more than 20% of their body, which complication is the most immediate concern? Is it going to be A, infection, B, hypothermia, C, hypovolemic shock, or D, renal failure? And yes, this is a harder test. It's designed for those nursing students who are either in or approaching their critical care term, or those nurses who are going back into the ICU. Maybe they've done education and they just want to refresh their knowledge. So let's see, when someone has a burn and thinking that the skin is the largest organ on the body. So anytime the skin is burned or altered, the person is going to be at risk of shock. So it is C. I know that was tricky. And the reason is because we've taken off the skin, the person's going to be dehydrated. So the answer is hypovolemic shock due to massive fluid loss through burn wounds is the most immediate concern in severe burn patients. So we have to put some type of covering over it right away in order to preserve and to prevent them from being dehydrated. And of course, we'll take care of the infection with antibiotics if they have any. But let's get them covered up first so that we can make sure they're not going to lose any excess fluids from their skin that's no longer there. Next one, which of the following signs indicates early hypoxia in a critically ill patient? Is it A, cyanosis, B, restlessness, C, bradycardia, or D, hypotension? Early hypoxia in a critically ill patient, what would you see first? I see A's, I see B's, I see C's. All right, giving you 5 more seconds. And so for you all who chose A, Cyanosis or turning blue is usually not an early sign of hypoxia. So give me another response that is an A. And I see about 7 of you have it right. So we'll reveal the answer now. If you chose B, you understand that restlessness, agitation, and confusion are early signs of hypoxia as the brain becomes deprived of oxygen. So that's why we always tell you to monitor your patient's level of consciousness. So your patient who was able to answer questions correctly an hour ago is now unaware of where they're located. They're thinking they're at home. They're trying to get out of bed. I want you to think of restlessness related to hypoxia. Recheck those vital signs, which include the oxygen saturation, because they could have hypoxia or low oxygen levels. All right, next, what is the preferred treatment for hyperkalemia with ECG changes? Is it A, calcium gluconate, B, sodium bicarbonate, C, insulin and glucose, or D, K-exalate? And this one's hard, so I'm only giving you 5 seconds. We'll reveal the answer shortly. So when someone has hyperkalemia, what is elevated? We know hyper means that they have more than. The kalemia refers to potassium. So when someone has high potassium levels, what do we want to give them? Revealing the answer in 3, 2, and the correct response is A, calcium gluconate. So this is for your critical care nurses, the medications that they'd be given. It stabilizes the cardiac membranes and hyperkalemia, preventing fatal arrhythmias. And now, if you said K-exalate, you weren't wrong, but K-exalate is usually not one of those emergency medications. K-exalate will cause the patient to have a bowel movement, and that will pull out the excess potassium. But when there is an emergency, we need to give something IV, something that's going to work right away. All right, so which medication is commonly used to reduce afterload in a patient with heart failure? And I know all of you are going to get this right. Is it going to be A, furosemide, B, morphine, C, nitroglycerin, or D, lisinopril? We want to reduce the afterload. Look, the heart isn't pumping. We want to help the heart out and reduce some of those fluids. How are we going to do it? All right, we're going to reveal the answer in 3, 2, and all right. So with the lisinopril, with the ACE inhibitors, it helps to strengthen the heart so the heart can pump more effectively. And so ACE inhibitors reduce afterload by opening up those blood vessels and improving cardiac output. And on top of that, the doctor may order furosemide or Lasix. But first, with the heart failure, let's get the heart pumping a stronger beat first, and then we can include the furosemide. So lisinopril is usually one of the common medications given. In a patient with acute kidney injury or AKI, which lab value is most likely to be elevated? Is it A, blood urea nitrogen? Is it B, hemoglobin, C, sodium, or D, albumin? Which of those labs refer to the kidneys? AKI, acute kidney injury. And I see so many correct responses. So, revealing the answer in 5, 4, 3, 2, and you all have it right. You know that in AKI, acute kidney injury, we're monitoring the BUN and those creatinine levels. And if they are elevated, it's normally due to the decreased kidney function and impaired waste elimination. All right, so which of these is the most important nursing intervention for a patient on continuous heparin infusion? So we have a patient who came in, they have a blood clot. We're going to start them on a heparin drip. And is it going to be A, are you going to monitor their platelet count? B, monitor their APTT levels. C, monitor their hemoglobin levels. Or D, monitor their potassium levels? Which of these are specific to heparin? I see you, Takoya. I'm cheering with you. Woohoo! All right, so for this one, we'll reveal the answer in about 5 seconds. 4, 3, 2, and looks like Marjorie has it. And so for you all heparin, we monitor the PTT levels. What we don't usually say is APTT, but it is activated partial thromboplastin time, and it must be monitored closely in patients on heparin to ensure therapeutic anticoagulation without causing excessive bleeding. So whenever a patient's on heparin, we're monitoring those PTT levels. A patient in the ICU develops sudden onset dyspnea, tachypnea, and also pleuritic chest pain. So, dyspnea, they're having difficulty with breathing. Tachypnea, they're breathing fast. And on top of that, they're having lung related chest pain. What should the nurse suspect? Is it A, pneumonia, B, myocardial infarction, C, pulmonary embolism, or D, neurothorax? And I see a lot of B's, but think about pleuritic chest pain. So that is chest pain that is originating from the lungs, from the pulmonary system. So the correct response would not be B. Give me another response. And Michelle and Vivian and Takoya and Marjorie, I see it. Yes, it is C. So sudden dyspnea, tachypnea, and pleuritic chest pain are hallmark symptoms of a pulmonary embolism. That means that a clot has traveled from the legs and has lodged into the lungs. So now they have a blood clot in their lungs. And so usually the patient will have chest pain, but it's not due to a cardiac nature. It's due to when they take a deep breath in, it hurts. So we would, of course, do additional testing, and more than likely, we're going to find a PE. And so PE is of course, a critical emergency. And your nurses, or once you're a nurse in school, you'll learn about thrombolectomies and how they treat patients who have blood clots in their lungs. What is the most appropriate intervention for a patient with a suspected air embolism? Is it A, place the patient in a supine position, B, administer 100% oxygen, C, place the patient in Trendelenburg and on their left side, or D, start chest compressions? And for this one, I have never taken care of a patient with air embolism. So I kind of knew what the answer was, but I had to research this one myself also. So let's see what you all think. And yes, Takoya says A or C. RA says C. Chrissy says B. All right, so I see a lot of B's. Michelle says C. We're going to wait for 5 more responses. Anne Marie says C. Danita just put her name in. Hey, Danita. All right, everybody, we're revealing the answer in 3, 2, and whenever someone has an air embolism, remember, air is going to rise. So if air is going to rise, we don't want the air to be trapped in their brain. So we have to put them upside down. So in an air embolism, placing a patient in the left lateral Trendelenburg position helps prevent the air from traveling to the pulmonary circulation while also administering high flow oxygen. So if you chose oxygen, that wasn't the incorrect response, but we have to change their position. We rather have that air going towards their feet than going towards their heart and their brain. So we do put them in an upside down position, which is referred to as Trendelenburg. A patient is diagnosed with acute pancreatitis. Which lab value is the most indicative of this condition? In other words, which of the lab values refer to the pancreas? Is it going to be A, amylase? Is it B, ALT? Is it C, AST? Or is it D, bilirubin? Which of those refer to the pancreas? I'm over here doing my nursing dance. I see you, Pearson. I see you, Pam. I see you, Evie and Chrissy. And so, since you already know this answer, the correct response is A. It is elevated amylase and lipase levels are the most specific markers for acute pancreatitis. Great job, team. In a patient with a chest tube, which of the following findings would require immediate intervention? Is it A, continuous bubbling in the water seal chamber? B, fluctuation or titling of the fluid in the tube? C, drainage of 20 mLs per hour? Or D, the chest tube dressing is intact? So we know it's not D because we want the dressing to be intact. So if it's not D, which of the others are incorrect? Let's see what my team says. Hey Takoya, I love the fact that you're here early. And we also at Florida Training Academy love being some of your first introduction into CNA and nursing. So welcome, and we can't wait to see how far you go with your nursing career. Okay, everybody, we're revealing the answer now in 3, 2, and for everybody who chose A, great job. Continuous bubbling in the water seal indicates an air leak, which requires immediate investigation and correction. And so that is an image of a chest tube or the actual container that holds the drainage. And so if you've never seen one of those before, there it is. And don't forget that you're not supposed to attach that to the side rails. It should be stabilized on the floor. All right, or another area, but definitely not the side rails. All right, so which medication is used to treat supraventricular tachycardia or SVT? So now we're thinking about those ACLS, those emergency drugs. Which drug slows down the heart? Is it A, atropine, B, amiodarone, C, adenosine, or D, dopamine? All right, I'll give you 10 seconds. ACLS drugs, which one slows down a really fast and narrow heart rate, heart speeding really fast? The person still has a pulse, and we want to give them a medication to slow the heart rate down. And so, revealing that answer in 3, 2, and I see you, Diana. It is C. It is adenosine. So, adenosine is the drug of choice for treating SVT as it briefly blocks the AV node, often restoring normal sinus rhythm. Don't forget to have the person vagal to bear down, to blow into a straw while you're trying to drop that medication, because sometimes vagaling will also help to lower their heart rate. Which of the following is a priority intervention for a patient experiencing status epilepticus? They're having seizures. Is it A, administer a sedative, B, suction the airway, C, protect the patient from injury, or D, administer anti-epileptic medication? What is the priority? Your patient starts seizing in front of you. What do you do first? And everyone has it right. You all are so awesome. The priority is C. We're going to protect the patient from injury. We're going to use the pads. We're going to put pillows against the rails. And then you press that panic button. And when the charge nurse or the other nurses come to help you, that's when we can give something to stop the seizures, such as Ativan. But your immediate concern is making sure that person doesn't fall out the bed or injure themselves by hitting a rail too hard. And managing a patient with sepsis, what is the first line fluid therapy? Is it A, D5W? Is it B, normal saline? Is it C, lactated ringers? Or is it D, half normal saline? When in doubt, just go at what you know. All right, we'll be revealing the answer in 5 seconds. 5, 4, 3, 2, And I see a lot of you all who chose different medications or different IV fluids. If there's an emergency, you want to go with the most compatible IV fluid, and that is going to be normal saline. So the response is B. Remember, that goes with pretty much everything. When you start hanging lactated ringers or you start hanging something that has dextrose in it, we're giving the patient other nutrients that they won't need or that may not be compatible with other emergency drugs. So normal saline is commonly used in fluid resuscitation to improve blood pressure and perfusion in septic patients, but then don't also forget that it is the most compatible of those IV fluids. So normal saline is usually the go-to. Which medication is used to reverse opioid overdoses in critical care? Is it A, flumazenil? Is it B, Narcan or naloxone? Is it C, atropine? Or is it D, furosemide? We're trying to reverse a drug overdose. Patient got out of surgery. They were asking for additional pain medications. The nurse didn't really pay attention, and level of consciousness change, and they're realizing, oh my God, the patient has their PCA, they have their pain pump, and now I've given these oral pills on top of it, and now the patient is heavily sedated, and they're having respiratory problems. So what drug would we give? If you chose B, naloxone or Narcan, you are absolutely correct because it is used to reverse opioid overdosing by displacing opioids from their receptors. So, yes, we would give them IV Narcan to reverse those drugs that we gave them to treat their pain. What is the primary cause of disseminated intravascular coagulation or DIC? Is it A, infection, B, hypotension, C, massive trauma or sepsis, or D, dehydration? Intravascular coagulation. So think about those words. What is happening within the vascular system? All right, I'll give you 5 seconds. In 4, 3, 2, and Jesse and Karen, I see you. Yes, DIC is often triggered by massive trauma or sepsis, leading to widespread clotting and bleeding simultaneously. So the correct response is C. And I see so many correct responses for that one. I bet you're at work like, hey, help me out with this one. In a patient with a spinal cord injury, what is the first sign of autonomic dysreflexia? Okay, so is it A, severe hypertension, B, bradycardia, C, chills, or D, sudden headache? So this is something that can occur in your patients with spinal injury. So you want to be monitoring your patients who are either paraplegic, quadriplegic. We're always looking for signs of dysreflexia. Okay. And so if we can prevent dysreflexia, we can prevent our patients from having some abnormal effects during our hospitalization. So I'm revealing the answer in 3, 2, and the correct response is D. So the first sign of autonomic dysreflexia is often a sudden severe headache followed by hypertension and bradycardia. And so the blood pressure increases, their face become red, they'll have headaches. If you're looking at their necks, their neck veins will also be distended, and then the heart rate starts to drop and they become diaphoretic or they begin to sweat. And that is sometimes caused because the patient hasn't relieved their bladder. And so that's why your patients who are paralyzed will usually be on a bladder schedule where if they don't have an indwelling catheter, they're going to be straight cath about every 4 to 6 hours so that we can prevent the dysreflexia. All right, so which of the following is the most common complication following a myocardial infarction? Myo, muscle, cardio, heart, infarction, cell death. So what happens after part of the heart dies? Is it A, heart failure? Is it B, pulmonary embolism? Is it C, pericarditis? Or is it D, stroke? I see a B, a D, a B. So we got the whole alphabet, but the A's are winning. And so you understand that when a part of the heart dies, the correct response is A. So a consequence of a myocardial infarction is heart failure. And heart failure is a common complication after a heart attack or an MI due to the damage to the heart muscle, reducing its ability to pump effectively. So, when performing an arterial blood gas or ABG on a critically ill patient, which artery is most commonly used? Is it the femoral artery, brachial artery, radial artery, or ulnar artery? So, in some facilities, especially on the floors, the respiratory therapist performs the ABGs. But in your critical care units, the nurses will perform the ABGs. So, where is the nurse inserting that needle? All right, revealing the answer in 5 seconds. Takoya's, just go put a needle anywhere. Takoya. All right, looks like we have an answer. So, Anshita, I hope I pronounced that correctly. Oh, hold up, that wasn't the right one. I selected the wrong one. So, for you all who chose C, you are correct. So, the radial artery is the most common site for arterial blood gas sampling due to its accessibility and collateral circulation. So, pretty much that same pulse that you feel when you're counting someone's heart rate for 60 seconds if you're taking your CNA exam, that artery, that's where you're feeling your pulsation because an artery is actually beating. That is where the nurse or the respiratory therapist will insert a small needle and they would obtain their blood sample. Okay, so an ABG is taken from the radial artery. What does an elevated central venous pressure or CVP indicate in a critical care patient? Is it A, dehydration, B, hypovolemia, C, fluid overload, or D, hypotension? Elevated central venous pressure. So if someone has elevated pressures, what do you think that comes from? And I see a lot of right answers. It is C. An elevated CVP typically indicates fluid overload or right-sided heart failure. So one of the questions I ask a lot in my ACLS classes is, yes, we're talking about fluid management when someone has a low blood pressure and you just want to go ahead and hang the IV fluids and just let it flow in fast. But I ask, how do you monitor for fluid overload? And most nurses forget the basics. They forget to auscultate. They forget to listen to lung sounds. Those coarse lung sounds, that shortness of breath, the jugular vein distension, that means something. If the patient, you have a whole bunch of fluids going in and now their lung sounds have changed, well, that's a sign that they have too much fluid. You are increasing their CVP. So back up on the fluids and don't forget to assess your patients even in an emergency, because yes, we want to get their blood pressures up, but not the risk of causing them to have respiratory issues. All right. So, which electrolyte imbalance is most likely to cause cardiac dysrhythmias? So, which electrolyte imbalance is most likely to cause the heart to get out of its normal rhythm? Is it A, hypernatremia, B, hypocalcemia, C, hypoglycemia, or D, hyperkalemia? And I just want to say her name. Hey girl. Hey girl has D and Cheetah says D. Barad, I haven't seen you in so long, Barad. Hey, says D. And Thea says B. So we're revealing the answer in 3, 2, and all right, so here we go, team. It is D, hyperkalemia. So don't forget, too much or too little potassium can cause your patient's heart to go into an irregular rhythm. So hyperkalemia can cause life-threatening cardiac dysrhythmias, including ventricular fibrillation. And don't forget, we defib for VFib. All right, so what is the primary concern in a patient with a massive pulmonary embolism? Is it A, hypoxemia, B, hypercapnia? Is it C, bradycardia, or is it D, hypoglycemia? Massive pulmonary embolism. So, what organs are affected and what happens when that organ is massively infected? I said infected, affected, excuse me. All right, I see some correct responses. So, if you chose A, you understand that when someone has a massive blood clot, that their oxygen saturations are going to be low because the blood clot is preventing the oxygenation of the lungs. So it's going to impair the gas exchange, and that's going to lead to severe hypoxemia. And in the meantime, while we're waiting for the doctors to come along, of course, you're going to add supplemental oxygen. But when someone has severe hypoxemia, we usually don't use the nasal cannula. We're going to go for one of the masks, and one of the most common masks would be a non-rebreather. So when you're thinking critical patients and you don't want their oxygen levels to remain low, we don't start at 2 liters and then slowly titrate up. We go ahead and get the non-rebreather, and then as they improve and as they stabilize, we can then titrate down. Of course, you'll be calling your doctor for the order, but I can pretty much guarantee if someone has severe hypoxemia, your doctor's not going to say put them on a nasal cannula at 2 liters per minute. All right, so in managing acute myocardial infarction, or MI, what is the most crucial initial treatment? And this gets tricky because we use an acronym called MONA. Okay, and so MONA stands for morphine, oxygen, nitroglycerin, and aspirin. But that doesn't tell you the order. So, which is the most crucial? Is it A, oxygen therapy? Is it B, nitroglycerin? Is it C, morphine? Or is it D, aspirin? I know they tricked you, and Gina, it's not C. All right, so I'm going to help you out. It might not be B or C, because what do either of those do with the blood pressure? If we give somebody morphine and their blood pressure is low, if we give them nitroglycerin and their blood pressure is low, we're going to bottom them out. So even though the acronym is MONA, it's not in that order. It's based on what your patient can tolerate. And so for all of you all who chose A, Jesse, I'm sorry, I meant D. So Faith, I see you. You are correct. So aspirin, if someone has an MI and you can't, their blood pressure won't tolerate the morphine. By the way, while you're trying to spike the bottle and connect it, that's an extra 2 or 3 minutes. You could have given them a chewable, a low dose aspirin, which will be helping to thin the blood while you're trying to apply oxygen and all this other stuff. So aspirin is given immediately to prevent further clot formation in a patient experiencing an MI. So usually aspirin first, and then if the person has, or if we are at a location that has sublingual nitroglycerin and their blood pressures can tolerate it, we will give them their nitroglycerin tabs under their tongue. But again, the blood pressure has to be stable. Which of the following is a major complication of mechanical ventilation? So we have this person intubated and we have them on the vent. What is a major complication? Is it A, pulmonary edema, B, hypoventilation, C, ventilator associated pneumonia or VAP, or D, hemoptysis? They're coughing up blood. What is a major complication? Something that will commonly happen if we don't have good caregivers who are conscious. What's going to happen to patients who are on a vent? And I see so many correct responses, and your nurse educator named Eunice, she goes, wow, because you all are going to make sure you use sterile technique, that you're going to be washing your hands, or that or you're going to be using an inline suction, because we don't want to introduce any bacteria or any germs into this person's trach until their ET tube. Because C, ventilator associated pneumonia is a significant risk for patients on a mechanical ventilation, requiring strict infection control measures. So most of your facilities will teach you, you'll go through a simple course and you'll learn about managing vent patients before they allow you to work with vent patients, because we don't want to give them pneumonia. In a critically ill patient, what is the primary reason for using a pulmonary artery catheter, also referred to a PA catheter? Is it A, to assess left ventricular function and cardiac output? Is it B, to administer medications? Is it C, to measure urine output? Or is it D, to monitor blood pressure? Why do we insert a central line in this patient's pulmonary artery? Person must be really sick. What are we trying to monitor? And if you chose, I'm so proud of you all. A, you are right. So a PA catheter provides detailed information on cardiac output, pulmonary pressures, and left ventricular function. If you haven't stopped to give yourself applause, I know Takoya has been applauding herself the whole time. If you haven't stopped to give yourself applause, please do so, because you all are doing wonderful with this review. All right, so what is the initial treatment for an acute stroke caused by a thrombus? We call that an ischemic stroke. So if a person has a clot that causes their stroke, would the initial treatment be A, anticoagulants, B, thrombolytics such as TPA, C, antihypertensives, or D, antiplatelets? And so far, I see Barad, you are right. Barad put his answer in twice. So let's tell you the difference, everybody. The answer is B, because blood thinners thin the blood. That is right. But TPA and thrombolytics, they break the clot up. So when someone has a thrombus, we need to dissolve that clot. So a new term that we're introducing to you today would be thrombolytics. A thrombolytic, or a TPA, is used to dissolve the clot in an ischemic stroke and is given within a specific time frame, usually 3 to 4.5 hours. So we call it a clot buster. When they say, hey, what time did the stroke symptoms start? And you're able to say, grandfather started having weakness on the left side of his body 2 hours ago. They know that your grandfather would be a candidate for TPA. Of course, they're going to ask other questions about recent surgeries, other medications, but let's just say for this scenario, grandpa can have TPA. He can have his clot buster. They're going to give him the TPA and then monitor him. And then a few hours later, they will start him on the anticoagulants, the drips, to thin the blood to prevent a new clot from forming. So I hope that helped you out and helped you understand the differences between anticoagulants and thrombolytics. Next, which intervention is most appropriate for a patient experiencing a hypertensive crisis? Is it A, administer furosemide, B, administer nitroprusside? Is it C, administer beta blockers, or D, administer fluid bolus? Hypertensive crisis, not just hypertension. So this patient's blood pressure is at stroke level. Which of these would be an ICU medication, something that you wouldn't normally give on a regular med surge floor? Revealing the answer in 3, 2, and yes, it is B, nitroprusside, because it is a potent vasodilator. It opens up the veins. It's used in hypertensive crises to quickly reduce the blood pressure. So it makes the vein larger, which thereby decreases the blood pressure. Which of the following is an early sign of respiratory failure in a critically ill patient? Is it A, bradynypia? Is it B, increased work of breathing? Is it C, cyanosis? Or is it D, apnea? An early sign of respiratory failure. I know it's one of two. Early, okay, I think I know this one. Otherwise, I'm about to be embarrassed. All right, team. We're revealing the answer in three, two, and yes. Okay, I was right. Early would be increased work of breathing. Late would be the cyanosis. So, increased work of breathing is an early sign of respiratory failure as the body tries to compensate for impaired gas exchange. So, we talked about restlessness and confusion, but also monitor how their chest is moving. And if you see them having difficulty with breathing, you see more of their stomach muscles moving, that's what we mean by the increased work of breathing. They're struggling to breathe, and that would be an early sign of respiratory failure. What is the primary nursing concern for a patient with a tracheostomy? So that artificial airway, there's an incision in their trachea, and usually there is a device that is inserted, and that is now their new airway. So what is the primary concern? Is it A, skin integrity, B, communication, C, airway patency, or D, nutrition? Uh, I see a lot of B's, I see a lot of C's, and now primary concern for this one would not be communication. Think of ICU. We're not, yes, we are kinder, gentler, we're empathetic, but when someone has an artificial airway, communication comes secondary to making sure that that airway is patent, that there's no mucus plugs in there, that you've been suctioning, that you use the humidifier or dehumidifier. All right, so maintaining airway patency is a priority for tracheostomy patients as secretions can block the airway. So we just don't want a whole bunch of dry air. If they have dry air, those secretions are going to get dry. So sometimes they'll have like a little tent that we put over their tracheostomy, or they will have it connected to an inline suction that also has heated air that flows through it. I said heated air. We'll say we'll say a therapeutic temperature air. We don't want it too cold. We don't want it too hot. All right. So which of the following is the most common complication of parenteral nutrition in critical care patients? So this would be somebody who is being fed via a tube. So what is a common complication? Is it A, hyperglycemia, B, hypokalemia, C, hypernatremia, or D, hypophosphatemia? I've had my coffee today, so I can talk better. All right, let's see what you say in the comments. Let's see. We have a lot of A's and we have a lot of C's. So let's see if we can get three more responses. Now we have a B and we have a C and another A. So 5, 4, 3, 2, and the correct response is going to be A. Hyperglycemia is a common complication of parenteral nutrition due to the high glucose content. And so a lot of patients, when we initially put them on their tube feedings, even if they are not a diabetic, we're going to be checking their blood sugar levels because now we are putting, whatever that supplement is. And I'll just say that it's Ensure. So Ensure not only does it have protein, but it also has some sugar. And so if we just dump, a whole can, of course, we're going to let it flow by gravity, but I said dump. If we just give them a whole can of tube feeding, and then we don't check graduals, we don't know how they tolerate it. They're probably already on steroids, which also increase the blood sugar levels. We are going to cause them to be hyperglycemic, even though they are not a diabetic. So anytime you start a new tube feeding on someone, you want to be checking those blood glucose levels also. All right, so which intervention is the most critical in managing a patient with an acute GI bleed? So they have a gastrointestinal bleed. That means that their stool is black, maybe like a maroon color, because of the digested blood. But what is your most critical concern? Is it A, administer antibiotics? B, insert a nasal gastric tube? C, administer IV fluids and blood products? Or D, place the patient in a Trendelenburg position? I expect everyone to get this right. We have a patient who is bleeding. What are we going to do? Revealing the answer in 3, 2, and Faith, Cadest, Chrissy. Yes, Kelly and Zamore, we are going to give them fluids. We're going to dump those fluids in them, and we're going to give them blood products because those are the most urgent interventions to prevent or to manage the hypovolemia and that's caused by the acute GI bleeding, but we also have to replace the blood that they're losing. And so fluids and blood is how we treat GI bleeds until the doctor can go in there and cauterize or burn off whatever area is bleeding. But we do what we can to manage it, and the surgeons and the doctors do that more advanced treatment. What is the purpose of using a sedative like propofol, also called Diprivan, in patients on mechanical ventilators? Why do we give them propofol? Is it A, to prevent blood clots, B, to reduce the risk of infection, C, to treat pain, D, to reduce anxiety and decrease the work of breathing? Woohoo! Romy, Marjorie, Barad. Hey, girl. All right, so we know that it is D. So, Diprivan or propofol is a sedation that reduces anxiety and helps with patient ventilator synchrony. That means that the patient's not trying to breathe over the vent, trying to pull the tube out, etc. And it decreases the work of breathing. So that is why when you often see a person who is initially on the vent, they're not responding to you. They're not responding to you because we have them on like this paralytic to where, they really can't respond, because if they do, they're trying to pull out their vent. So we start weaning down the propofol, weaning them off completely, hopefully giving their lungs time to rest without them fighting and breathing over the vent. So we're going to give them an opportunity to allow their lungs to heal themselves. And most times it is effective and it does work. All right, so which of the following rhythms is a priority for synchronized cardioversion? Synchronized cardioversion, this person's still alive. So you're going to be shocking somebody who's alive. Why would you do that? Is it for atrial fibrillation, ventricular fibrillation, pulseless electrical activity or PEA, or ventricular tachycardia with a pulse? Why are we going to use the setting, the synchronized cardioversion setting? What is going on with that person's heart? I see A's and I see D's. I see A's and I see D's. And technically, you're not wrong if you say A, but we have to make sure it is tachycardic, because atrial fibrillation, just saying that could just mean that they have fibrillation waves, but a normal heart rate. So the heart rate is 88. We're not going to synchronize cardiovert this person. But when someone has a fast heart rate and they are symptomatic, such as what's in this image here, the response is D. So ventricular tachycardia. Tachycardia means that the heart rate is greater than 100. So ventricular tachycardia with a pulse can be cardioverted to restore normal rhythm before it progresses to a more life-threatening condition. Let's go to our next one. What is the first step in treating anaphylactic shock? Is it A, administer epinephrine, B, administer, that's another word for Benadryl? Is it C, administer albuterol, or D, provide supplemental oxygen? Now, anaphylactic shock, that's a biggie. Their airways closing. Their face is flushed and red. Their heart rate's increasing. Are you going to administer epi or Benadryl? And so revealing the answer in 3, 2, and yes, it is epinephrine. So epi is the first line treatment for anaphylactic shock. Think of the EpiPen. When someone has severe allergies, we're not like, hey, let's give you some Benadryl. It's like, oh no, we have to reverse everything that's going on in your body. So epinephrine counteracts the severe allergic reaction by dilating or opening the airways and increasing the blood pressure. It's fine, Kelly. You're amongst friends. No need to say oof. All right. So, which complication should a nurse monitor for in a patient receiving total parenteral nutrition or TPN? I call these my bags of steak and potatoes. So, when your patients can't tolerate food via the oral route, and maybe they're not sick enough to have a gastric tube, we're just giving them a break for maybe 2 or 3 days. We're going to start an IV and we're going to give them their steak and potatoes intravenously. So, what are we monitoring for? Is it hypoglycemia, hypovolemia, infection, or hyponatremia? The fact that I said IV should give you a hint. We have a person who's receiving steak and potatoes via an IV. It's a lot of nutrients, a lot of sugar going through an IV. So, revealing the answer in 3, 2, and that person's going to be at risk for infections, you all. Look, we have this whole IV bag and tubing with nutrients that germs would love to get a hold of. So you have to make sure that you, of course, wash your hands, that you clean and scrub that hub, that you keep that tubing as clean as possible, because patients on TPN are at high risk for infection due to the central line and the rich nutrient solution, which can be a medium for bacterial growth. And so usually with the TPN, it's customized. It's based on the patient's needs. So they shouldn't be low on anything because they do blood work every day before they get a new bag of TPN. So they will not be hyponatremic. They will not have hypoglycemia. So they won't have anything on the low end, because if they do, that is what the bag of TPN is for. It's to actually give them the nutrition that they would receive if they were able to eat. Our next one, in a critically ill patient, what is the main indication for continuous renal replacement therapy, or CRRT? Is it A, fluid overload unresponsive to diuretics, B, hyperkalemia, C, hypotension, or D, hypertension? So C was hypotension and D is hypertension. Person who has kidney failure, why are we going to use CRRT? I'm happy you're enjoying this. All right, so I'm going to reveal the answer in 5 seconds in 4, 3, 2, and I see answers all over the place. So this one's going to be a new one for you all. I see that Barad has it. The correct response is going, and Karen has it too, is going to be A. So CRRT is often used for critically ill patients with fluid overload that cannot be managed with diuretics, especially in those with unstable hemodynamics. In other words, their blood pressure is too low. So this person's kidneys have stopped working. What do the kidneys do? They filter. So they remove toxins. They also remove excess fluids. But because the kidneys are not working, the person becomes toxic and they hold on to the fluids, which can put them into congestive heart failure. So what we're going to do instead is connect them to a machine that is going to pull out those extra fluids without causing their blood pressure to drop. The problem with giving them furosemide or Lasix is that it's indiscriminate. It's just going to pull out all the fluids, but if the person can't make urine because their kidneys are so bad, now we just have fluids in the body trapped in the body. So that is why the I can't even say it, the diuretics sometimes don't work as well with patients who have renal disease, and they have to be put on dialysis or CRRT as another method to clean their blood and also remove the extra fluids. Which of the following interventions is appropriate for a patient with acute coronary syndrome? Is it A, administer beta blockers, B, administer IV fluids, C, administer aspirin, or D, perform chest compressions? Let's think this through. Acute coronary syndrome sounds like a big fancy word for something that means heart attack. So you all are right. It is C. You're going to give an aspirin. So aspirin is part of the initial treatment for ACS to prevent further clot formation in the coronary arteries. And so many of you answered that one correctly. What is the primary intervention for a patient experiencing a tension pneumothorax? Is it A, insert a nasogastric tube, B, administer oxygen, C, perform a needle decompression, or D, administer a diuretic? Tension pneumothorax. I'm doing my nurse dance because you all are smart and I'm loving it. You all are right. It is C. We're going to do a needle decompression, which is an emergency intervention to release the tension pneumothorax. And that's going to relieve the excess pressure from the heart and lungs. Right now, they have air where they shouldn't have air. And so the doctor's going to insert a needle. This one has a needle and a catheter, but they'll insert a needle in order to get that trapped air out of the lung, out of the pleural cavity. Next one, which of the following is a complication of long-term mechanical ventilation? So there are patients who we cannot wean them off of their vents. They are going to be on a vent for the rest of their lives. What would be a long-term complication? Is it A, atelectasis? Is it B, ventilator-associated pneumonia? Is it C, pulmonary embolism? Or D, hypertension? I see B's, I see A's. I see another B, I see C's, I see A's, I see B's. All right, so I'll reveal the answer in 5, 4, 3, 2, and I see the right answers. Yes, whenever someone's on a vent long term, they are at risk of getting B. Ventilator-associated pneumonia is a major complication of long-term mechanical ventilation requiring careful monitoring and infection control. So this is an x-ray, and those white areas are areas that are filled with fluid, and so that would be the area where the pneumonia is located. So you keep turning those patients, even though they're bedridden, encouraging them to cough. And sometimes they'll put like a vest or some type of compression vest on them. I shouldn't say compression vest. It's a vest that's going to help move secretions. And for whatever reason, I cannot think of the term right now. So if someone can think of the term, please put it in the chat. But it's like a vest that vibrates. And so since this person may be unable to cough on their own, we're going to help move secretions from the outside of their body by just stimulating the chest and the back muscles. All right, so which lab value is indicative of sepsis? Ooh, is it A, elevated white blood cell count, B, low hemoglobin, C, high platelet count, or D, elevated calcium levels? And I know every one of you are going to get this right because only one of those lab values has something to do with infections. Yes, great job, team. So everybody put in A. An elevated white blood cell count is commonly seen in sepsis due to the body's immune response to infection. What is the most important initial assessment in a patient with suspected acute respiratory failure? All right, so we're in the room. What's one of the first things you want us to do when our patient is not doing well? Respiratory rate is 6. All right, so what are we going to do? Is it blood pressure, respiratory rate, arterial blood gas, heart rate? And I kind of gave the answer. I said the respiratory rate was 6. So we're not really counting the respiratory rate at this point. We're trying to do something a little more advanced than that because you're in critical care. This is your critical care nursing review. And so for this one, if you chose C, we're going to do that ABG. We're going to do arterial blood gas. Look, I'm looking at the patient. I know they're not breathing well. I'm looking at the pulse oximetry. I see their O2 set is low. What is next? Next is going to be that arterial blood gas because it provides critical information about oxygenation, ventilation, and acid-base status in respiratory failure. Oh man, we're done already. Oh, I had so much fun with you all. And so, if you have stayed to the end, please like the video. Don't forget to share. Thank you all for commenting and making this so engaging. And tomorrow, I think there will be Phyllis and also Saskia. So, Saskia translates the videos into French Creole or Haitian Creole. And then Phyllis will also be on tomorrow and she'll have a practice test too. So before I leave, are there any questions, any comments? I appreciate you all so much. And I thank you all for staying this long. Let's see what's in the chat. You're so welcome, Faith. And Takoya, I'm happy you had fun. Brad, it's so great to see you again. And I think I missed some comments. Nichelle and Kelly, you're welcome also. And Kadesh, we are praying. Oh my God, you take your test in a few days. So yes, we're praying for you. And we expect to hear that you pass your test next week. All right. So if you all don't have any questions, I'll be leaving the line and I will see you all in our next video. If you want freebies, don't forget to go to our website, which is fltraining.com. Click on resources and then you can download our free study guides and other materials. All right. Until tomorrow, everybody. Oh, Felicia, we have 2 lives tomorrow. And then I probably won't be on again until Thursday or Friday, but I will post it in the community section. All right, everybody. TJ, you're welcome also. Bye, everybody.